So over here, now you can see the whole leg has been covered with the collagen dressing. Can you see the collagen dressing? And if it goes to the normal skin a bit, it is. I think 3:15 we are supposed to finish, so I'll try to stick to my time. Just to go through, so we know the steps of the procedure now. We take a skin graft, we trypsinize it, we do the cell separation. These are our melanocyte keratinocytes. So we have achieved separation of skin, then we prepare the recipient side, either with, you can't even make out she's been operated. So the results that you can achieve. Another patient, we operated the lip, the chin, and you can see the uniform color, the repigmentation, pretty evident. Sometimes it's possible that some areas do not take up, so it is important that you counsel the patient accordingly. No vitiligo surgery where the sponge, Jodhpur or something can say that okay, we're going to recover you 100%. If something is left out, patient has to be counseled. They need a touch-up surgery which has to be done if required after 3 months. And so we can do any area starting. Remember is leukotrichia. Patients who have leukotrichia, later there's a possibility that some of the hair will get pigmented, but it is not a very sure thing, and you're not in a situation to really tell the patient how much of hair also will be repigmented. Over the acral areas, a difficult zone to do. So the problem is stability, and what I have seen that in spite of doing the whole hand, this zone is still very, very resistant. Somehow there is some activity which is going on over there, and so again you see the whole hand has repigmented, but just centimeters square in one. Patient was on steroids for a long time, unnecessarily she developed dry. So with just 60 centimeters from the thigh, we could repigment that. We can do the nipple areolar complex. And again, understand the most important thing. Is your skin creases are preserved. You don't lose any skin. Look at this amount of bleed. Can you see? It's not like a pinpoint bleed, it's a more irregular bleed, it's a reticular. So I've gone pretty deep inside, but still we couldn't get the tattoo out. And this is when the cells took up, but a bit of the tattoo is still showing. Other option is you do a Q-switch ND-Act 1064 or 532, whatever according to the pigment, and but that again is going to take 1 to 2 years to get the pigment out, and then you do it. Post-operative depigmentation, as we discussed, put the patient on antiviral pressure liquid. We also did on a case of bipartisan, this girl child we've been doing. So we did her forehead, we did her neck, then we did her chest, another bipartisan. So that you can also do it post-burn depigmentation. So this is an excellent some psoriasis without explanation, and it has phototoxic blisters and it was scar, so we could repigment it, but obviously the scar is not going to get better. In scarred areas, you can see you can repigment. Again, as we understand in our country, the vitiligo is a problem, the scar is not the problem. As long as the vit is not there, we are fine. This was one very atrocious surgery done. It was ridiculous. Pretty much corrupted and put some split thickness. So we try to redo these cases. We have done a couple of them now, and corrective surgeries are more tough always, but you can think about it, you can plan it. Hello, thank you so much.
Difficult areas which very few people can take the chance of doing it. I request Dr. Niti Kumar to come on the stage, and she will tell you about acne scars and how to remove them. She is also from Delhi. A famous lady.
Wish you all a very good afternoon. At the outset, I'd like to thank Dr. Datta and his entire team for having invited me to the holy city of Varanasi. I will be speaking on procedures and active acne and acne scar management. A lot of options. We've discovered some of them today, and I will intend to do it tomorrow also. And the same thing is with acne scars. You have a basket of treatments, and if you really want to treat acne scars, you have to know quite a few of them, not all. I will be starting with some of the very simple techniques which have no conflict of interest, that many of these can be just treated with simple instruments. And so what are the learning outcomes? One, you should learn the art of various procedural modalities in active acne. Active acne can be treated medically, but if you add a some procedure, it hastens your treatment. So you can do that. You should know how to choose the right technique. You should know, it's very important to know the pre-procedure and the post-procedure care, how to manage complications. Complications come with everyone, with any simple procedure. It can come even with beginners as well as experts. If you've not had complications, it means you're not doing results by combining treatment. That is a buzzword nowadays. That's how you combine treatment. If you see in a thali, it's like a thali. You eat so many things at the same time. So that's how you should learn how to combine treatments. I'll be telling you about it. Dynamic therapy, which has not started as yet in India, which I hope to start in the next 6 months. So what is the aim of doing a procedural treatment in active acne? The aim is to prevent scarring. If a retinoid patient is just getting married and doesn't want, may want to have a baby, so these are some of the contraindications of, there are side effects to isotretinoin which patients don't want. So in such cases you can treat nodules and cysts. This is the pre-procedure care. It is very important that you continue the anti-acne medication. Priming is again very, very important. Prescribe a non-comedogenic sunscreen. Use skin lightening. Agents, I prefer to use either hydroquinone or kojic acid. Use a retinoid. That is again very important because it also helps in early healing. So you can use either adapalene or retinoid. Tazarotene only if the patient has a very thick oily skin, others by and large you should avoid it. And a non-comedogenic moisturizer. This is very important again. If the patient has a lot of dryness, so I won't go into the details of how you do the retinization. Is to do the retinization of the skin before you give any procedures, because if you're doing a chemical peel and if the patient has dry skin or hot spots, then you get more side effects, you get more PIH. So it's better to avoid that and get at least for 2 to 3 weeks to make the skin smooth before you do a procedure. This is the post-procedure care, and it's off-label. I like to use a lot of tranexamic acid, either over. This is simple comedone extraction, especially when there are closed comedones, macrocomedones, or there are submarine comedones. If there are closed comedones, what you do is that you just either pierce it with the (18-gauge needle), or even if it's a very tiny comedones, you just pierce it with a 26-gauge needle and then you extract it out. Don't forcefully do it. And you can see this patient's got multiple comedones, so don't be forceful with your comedone extraction. You could also use the radio frequency, use the needle electrode, just touch it lightly and then remove it. Macrocomedones, these were all closed. So here what I did was just electrodesiccation, did the comedone extraction and immediately follow it up with a chemical peel. You can combine both the procedures together, and here I use comedonal acne. Then intralesional steroids are also very useful for treatment of nodules and cysts because they reduce inflammation, they cause rapid involution and minimize scarring. It's very important that you use a diluted the transdermal astronide. What we get is 10 milligram per ml. Don't use it per se. Dilute it at least to either 5 or 2.5. So you can dilute it with saline 1:4. Or 1:2 depending on what strength you want. More than 0.1 ml per centimeter, so very little, and you can do it by the withdrawal technique rather than the multiple culture technique. And you always combine this with medical therapy. So this is a young boy who had multiple. He was the father of Indian dermatosurgery, and Dr. Bose is here. We learned so many things from him. I have slightly modified his techniques. So this is what it is about.
चल रहा
खबर ले जाता सर ओके ओके
well, in the first, it's motion, I don't know this normally as well, is to give local anesthesia. Here it's important that you give the local anesthesia.
प्राइवेट में बहुत ध्यान रखना होता है सारे पेड़ पेशेंट होते हैं मंडी ऐसा
So once all the pus has been drained out, you take a toothpick, dip it in 88% phenol and just go all around so that all you destroy the walls of the cyst. That is the whole purpose of using the phenol. This is how the phenol is being done at all directions. All around, you have to destroy the walls of the cyst. Otherwise, if you don't do this, it will recur. And if it is a very large cyst, you make a nick with a 15 number blade along the RSTL. So go along the RSTL, and even if the phenol spills over on the surrounding skin, don't worry, nothing happens. After you do the phenol, so it's a very large cyst, and that's why I'm going all around. So you can see this boy, he had this very large cyst, and when it has healed, there's no scarring at all. So that is why if the phenol spills out, don't worry. Coming to chemical peels. Peeling of the skin is very useful for active acne. It leads to reduction in comedones, reduces pH, reduces scars. It also improves photoaging. What are the peeling agents? Use lactic acid, or you could use a combination peels. So this is just a summary of the different peels you could use. How do you choose the peel according to the patient's skin and the type of lesions which are there. This is with salicylic acid. Even in a dark skin, this is mandelic acid. And then how do you prevent acne scars? So the basic 5 principles are: you treat acne early, appropriately and adequately. That is a key to preventing scars. Lasers and lights have also been used. You can use IPL, but I don't have much experience with that, because right now our IPL has not been working for quite some time, but it has been used. These are some of the lasers and lights which have been used for active acne. Now I he came to me in this. If he had been treated earlier, if he had taken adequate treatment, I'm sure he would not have landed up in this. This unfortunate boy did not take much treatment, and that is why he landed up with. So how do you approach a case of acne scars when it comes? You first have to evaluate, take a good history, see if there are still some factors by which you're getting the patient is likely to be active again. The activity of acne or any comorbidities. This is very important. When we just see acne, we don't have spent the first consultation, at least counseling. You will, even if the patient gets a complication, you will not have a problem. So in the counseling, first of all, you have to have an expectation alignment. What is that? You know, when a patient comes and you do procedures, they expect that all my scars should go away. It is, and especially those who are seeing YouTubes, they're seeing Instagrams, They believe that once I go and get treatment, my scars will totally vanish away. You have to tell the patient, no, it will not. It takes time. And secondly, you may not have that much of an improvement as your time. You know, when you do a procedure, it takes time for the skin to recover, especially for a procedure like the cross technique. And they will not look good, it will look odd in the first 5 to 6 days. And if the patient is not expecting it, the patient will get angry and say, you spoiled my skin. I had an important function and I looked worse. So if the patient gets a complication, then they are going to get very, very angry. So if you tell them that this can occur, but I know how to treat it, you don't worry, then the patient gets reassured. Then you have to plan your treatments. How do you start? You start, my way of doing it is I tell the patient which is your most important scar, which you feel really looks the worst, and it's preferable to first try and treat those so that the patient immediately feels much better, and then you can execute by having a good knowledge about the scars. Counseling is very, very important. Never underestimate the power of a good counseling session, and if you feel the patient is not convinced, you can call the patient again. So the step one is starting is evaluation. So you should rule out the comorbidity conditions, especially metabolic syndrome, polycystic ovarian syndrome, topical steroid abuse. Many of these patients would be using topical steroids, and when you stop them, they start getting a lot of redness. They start getting a sensitive skin, and this makes them more prone to getting PIH. So be careful of that. Plan your treatment according to the recommended. Then the ice pick scars, all these. So I won't go into details. And how do you evaluate? I talk about 5D. First I used to talk in my previous lecture about 4D, but now it's 5D. What you look for? You see the shape, the size, the depth, the texture, and more. Important is the stretchability. But actually it's a rolling scar. So stretchability is very, very important to test. And lighting is also important. This patient came, and when I saw him, I said, you don't have too many scars. He says, no, you see angled light, same time, but see the light. And that's what patients will tell you. I go out in the sun and my scars look. So there should be a dialogue. Give some time to the patient to ask all their queries, and nowadays all the Google and Instagram patients have a lot of queries. So be patient with them and listen to all their doubts. Then only you'll have a satisfied patient. So this is the grading of scars, and this is the amount of improvement they will get. If it is grade 1, that is they are just macular, I tell them you will get 100% improvement. If it is grade 2, then the improvement is 80%. This is the Goodman-Barron classification, which you must know. It's a very simple grading of scars. Grade 3, I tell them improvement is 70%. And if there is very severe scarring, I don't promise more than 50 to 60%. Third step is planning. So how do you plan? See, this is the basket of all the treatment which is available. At least the basics you know. So the topicals, chemical peels, cross, ILS we all can do. The EVDs, if at all you have, fine. If you don't have a laser, you can still treat. Surgery. Fat transfer is an advanced technique and even dermal grafting, but it is not that difficult. If you learn it from somewhere and then you start doing, you realize it's a very good technique. Then microneedling, you can do PR. So these are the four basic principles. Even out the color differences, elevate the depressions, efface the elevations, and enhance the texture. All patients want an enhancement of texture, and these are the different ways by which we can follow all our four principles. So how do you target? It depends on the problem. You could use a Q-switch ND-AG laser for very persistent lesions, and or if it is depigmented, we do get sometimes hypo or depigmented scars. I use topical tacrolimus or TCA. And if you have, and the scar is not improving, you could use an excimer laser. So you see, if you follow these principles, it becomes quite simple. The stretchable scars and the non-stretchable. This is how I divide. If it is stretchable, this is what I would do. I would start with a subcision, microneedling, and a biofiller or a PRP. Hyaluronic acid filler, the patient hypertrophic or keloid, you need the intralesional steroids, or you could do an intralesional radiofrequency ablation. For the papular scars, do an intralesional radiofrequency ablation, or you could use a erbium glass laser if you have it. If there are bridging scars, then you have to excise the scar and repair it by doing scar revision. Then after all you've done this, patients still say, still my texture is not good. So how do you improve the texture of the skin? And that is how we also improve the texture of burn scars. So you can do either fat in, if you do nano fat, it really improves the texture because it supplies stem cells. You could also use a PRP or a biofiller, microneedling. These are all for improving or enhancing the skin texture. Priming, as I told you, is very important for all acne scars. For macular scars, this is my go-to treatment. I start with topical agents, then do peels. And then IPL or PDL if you have it. Otherwise, with just peels, they do improve, and topical agents. So this is the salicylic acid. Took 4 sittings at 2 weekly intervals. This is salicylic mandelic acid. This was a gel-based peel because she had very sensitive skin. Now coming to the atrophic scars, if they are shallow, you can combine the subcision, the PRP with PRP, nothing else. Just 3 sessions at monthly intervals. For the very deep scars, you have to follow it up with punch techniques and then do a resurfacing, and if the texture is very poor, the fat transfer. This is for lipoatrophic scars. No amount of laser is going to help this patient. You have to increase the volume, and if you use a filler, it will require a large amount, be very expensive. So that is why fat grafting is very useful. So now we come to how do we execute all our cord needle, a blunt cannula. There is a new instrument called as a Taylor's Liberator, which is a U-shaped. It has a U-shaped tip which is very sharp at the proximal end, or you could also use a RF subcision. So this is you can see is on the extreme. Right is the Taylor's Liberator. A blunt subcision is where you have a single entry point and you're using a 70 mm 18 gauge cannula. You just subcise the entire area. This is just, I don't do this, I prefer using a very focused sort of subcision. This is what I prefer to do. I take an 18 gauge needle, I take a sterile artery forceps and bend it at right angles, and then you choose the gauge of the needle depending on the size of the scar. So if it's a small scar, you can use even 22 to 23 or even 20. Part of the needle prevents it from going further in the skin. I was trying to show the pointer. So here you can see how it, when you go in that flat plane, your needle will not go further. This is focus subcision. This is the size of the needle you can use to they're just open pores. You can use a 26 gauge needle. If there are, and remember that the size you choose, the scar should be less than the bevel of the lesion. So in ice pick scars, use 22 to 23 gauge. For rolling scars, 18 to 21 gauge. And for boxcar scars, again, 18 to 21 gauge. Here, what I do is I give tumescent anesthesia. I dilute 1 ml of subcision on. Because when you do subcision of the entire face, it leads to a lot of bleeding. It leads to hematoma formation, and it can later on you can get fibrotic nodules. So that is why I prefer my focused subcision. You can see, and I'm talking to the patient. She's hardly having any pain, and this is just doing subcision very adequately.
Dr. Niti,
Yeah.
can I ask a question?
Yeah, sure.
I have had some patients in which, we were doing subcision and they felt The surface area of the scar has improved. Increased.
Yeah, or especially even if we do put in a filler, the scars which was more contracted is the diameter of the scar has increased, and they say my scars are looking much worse. I mean,
that would happen. That would happen only for the ice pick scars because the ice pick scar is a narrow tract, and when you subside it, it comes up. So it shows as if it has become wider because it has come up.
no, there were box scars. There were box scars. So, like,
Are you doing a focus subcision or subsidizing the entire area?
focused. And
Just
also,
individual scars.
and also if I put in a little bit of filler,
So it kind of increases the surface area of the scar.
if you understand what I'm saying.
No, yeah, I understand what you're saying, but the surface area should not increase. If the subcision is not proper, what will happen is that the filler may where the fibroid. You're not stretching the skin.
It does stretch out, right? Like you give the tumescent, the skin does appear. Its whole thing is stretched. So the surface area is increased. This is obviously local, it's going to wear off.
Yeah.
But a hyaluronic acid is going to hang around for a long time.
Then don't do sessions of subcision before I put in any either a biofiller or the fat. If you put in too much of filler, it's going to pop out and expand. So I think you need to control the amount of filler you are putting. But per se, the subcision will not.
No, not with substitution with filler.
Yeah, it's a filler. Yeah,
Filler.
yeah, and it's the filler done with just
Central
yeah. So if they have few scars, they'll get the donut. But if they have lot of ice pick scars, they'll get the podium. Yeah. So subcision for 2-3 sessions, and in your final session, you give the filler. And sometimes what you can do, I call it hydroscission. I didn't mention it here. Is that I just put saline, and by this you know how much of this you want to inject. Yeah, so because it goes away in 2-3 days, and it's also a good technique. If patients have some very important function. The modified subcision, you take a sterile 18-gauge needle, you first make a bend at 90 degrees, the bevel should be facing upwards, and then you make a second bend at the other, I hope you could see it. So you see there are these two bends. You have two bends, one here and one here, and it's mounted on a 2cc syringe. could also put PRP in the syringe and inject as you can with anesthesia, and then again you can see that the scars are, the prominent scars should be done away with first. And you can change the needle according to the size of the scar, so that it makes it very versatile, very simple, rather than using a no-core needle. I have used once or twice a Taylor's liberator, but it's a very crusting. So this is the subcision. Same thing now on the other side. This is playing in slow motion, but otherwise it's a very quick procedure. You just go very quickly. Any questions on this? Please feel free to ask questions.
One thing, every time I see there's a hematoma when you're using a little big needle and
to make sure the hematoma don't form.
For the size of the needle, I showed you. If the scar should be smaller than the bevel. So if you have a small ice pick scar, you use 23 or 24 gauge. Only if it's a large boxcar scar, then you use an 18 gauge, otherwise you avoid it. Second, you
that's the place where you get
yes, and you enter, the bevel is triangular, so you try and enter along the RSTL, so that because there is a small minor linear wound which is created, that should be avoided. And second, when you are doing tumescent anesthesia with the adrenaline, there is hardly any bleeding, so the chances of hematoma are much less. In fact, I have hardly seen any hematoma. It's only when very extensive subcision is done, that is where you get hematomas.
tumescence is the
Tumescent, yes.
One more thing, Dr. Niti.
Yes.
This tumescent anesthesia is fantastic. Usually, I have tried with these needles. After some time, it loses the
RF subcision also.
Okay, I didn't show the video here, but in the RF subcision, you can do it in two ways. One is they have a special needle, which is an insulated needle. You just go beneath the scar and just, it's the same the way we do with this, except that it has RF energy. And so it's very smooth. But a little of the RF energy does go up, so you get a little crust on the surface. And that is why I, by and large, avoid it, unless it is very thick hypertrophic scarring.
But
So
are the results substantially, significantly better?
No. It's only it is much faster. That's all. Nothing much.
Thank you.
I prefer using the RF for the hypertrophic scarring rather than just for the simple atrophic scarring. Because in the atrophic scarring, you have to be very careful about the level. As I told you, I have seen some patients get a little crusting on the surface, so I, by and large, avoid it for the atrophic scars, but it's a very smooth procedure, that's all.
one question.
Then I come to the incidence of PIH is much less with the phenol. So this is what you have to do. You should go perpendicular and create very pinpoint frost. Here it's very important that here the acid is very important, does not spread to surrounding normal skin. Otherwise a small ice pick scar will be converted to a bigger boxcar scar. And if my so this is the procedure. This is the phenol cross. This is the most important part of the procedure because a toothpick is very broad. It has a pointed tip, but suddenly it becomes broad. So you have to sharpen the toothpick and see that it is quite fine, even a little above the tip. This is what I consider. This is a mistake, I didn't edit it. Can someone tell me what happened? What's the mistake you make here? Not you, Mudish. Any
Kept the bottle nearby.
yeah. Keep it at the side. And then go, and this is how you get with the phenol also. You get a very quick frosting. What's important is that it should be very pinpoint.
Did you anesthetize that area?
No, it doesn't. Require anesthesia. With phenol, in fact, there is less. You don't need to. I just cleaned it with saline because once it has frosted, then you really don't need to do it. But here, what I want to emphasize is that it should be very pinpoint. And if you're doing the entire cheek, be very careful of your non-dominant hand. It should not. If whatever you have been doing, pre-procedure priming, what I told you, sunscreen, skin lightening agents, tretinoin, which this you should continue. The tretinoin you start once the scabs are fallen off. And here it is very important to tell the patient that don't remove the scabs. They look very odd. I tell them you can apply some the linear scars, and you can see this is the patient who came with ice pick. All ice picks, all patients who say I've got open pores are basically all ice pick scars. They are not just open pores. The pores are not opening. They have had mild acne, and these are all the ice pick scars. And this is just with 3 sessions. Outside that she came and said that I had very tiny scars and they put something and my scars widened out. This is what she developed. So this, you should be very careful, do it very patiently, let it frost, do small areas at a time. Once frosting occurs, then it will not spread. And stretch the skin, go right to the bottom of the scar. So this is, that was a phenol. This is with a TCA. The procedure is almost the same, nothing different in that. This is how you must make the toothpick more finer. Stretch the skin and go right and perpendicularly right to the bottom of the scar. This is the pinpoint frosting which you should get. Acne scar treatment using the laser. And it's the advantage of this, it is safer because the beam is already pinpoint and it is much faster, but I feel results are slightly better with the cross technique as compared to the laser. The microneedling, there are minimal chances of scarring. Sometimes with the derma roller, if especially if it's a little blunt or if you're reusing it, you can get this tramp track sort of appearance. And it is very good for small areas and uneven areas like the eyelids, and you can vary the depth. So I prefer the derma pen as compared to the how the differences between the you see the derma roller creates these angular pores, whereas here it is straight. I'm using a derma roller when I didn't have a derma pen, and this is this patient had a lot of erythema also, that's why the bleeding is more, and then I just rolled it out. This is another when my derma pen came. So this is the derma pen. Derma pen. Yeah, this is not how you just pinch up. When you have a deep scar, you pinch up the scar. You have to remove the bridge and then repair the scar. So all such scars you have to do punch techniques. No amount of CO2 laser, even if you have the best in the world, will really help you to treat this. These are the different techniques: punch elevation. You do when the texture is relatively normal. Punch grafting, if it is a scar more than 3 mm, then you can do a graft. You can take either from the post-auricular or you can take even from the buttocks of the thigh. You can do an abraded punch grafting, I'll show you that. If it is more than 3 mm, Then you excise the scar and you suture it, and especially if it is very atrophic, it is best to excise and suture. So this is punch elevation or flotation, and it is a useful technique if there are many scars together. And then you can just, this is the punch elevation, you can see it is level of the skin, and you can just put a steri strip to stabilize it, remove the steri strip after 1 week. Abraded punch grafting, here you abrade the epidermis with the with a micromotor, you take the graft, you abrade the recipient area, excise the deep really improves. So she wanted a very quick treatment for this. So this is the abraded punch grafting. And you can see there is a little PIH, but it has healed. The advantage of abrading is that the reepithelialization takes place from the surrounding normal skin. So the relative texture is well maintained. It doesn't, you don't usually get those ring-like scars which you would get otherwise when you're then sutured along the RSTM. Same patient on the other side. This is the gradual. Sometimes there are little PIH remains which you can improve with topical agents or with peels. You choose the punch size just a little wider than the scar. And see, and you pinch it up. If it comes up very easily and remains there, that means your depth is fine. Now a bigger scar, so that's how you just go on doing it. This is the abraded punch grafting. You abrade the donor area. Some have been put, some have been sutured, so that's how the large grafts you excise and suture, and some you put the grafts, so you combine all the techniques.
The dermabrated punches, the side doesn't matter, right?
No, size doesn't matter.
No, what is up, what is down doesn't matter.
What?
Like what is up or what is down does not matter?
Yeah, but generally it's better to have the upper side up in case you have a few epithelial strands. Then you get a small cyst like this, it's better to be up.
But then how do you?
So these are the energy-based devices. There's been you can go through this article. It's a recent, it's a summary of all the energy-based devices. This is the CO2 laser, the 4-tier technique. In step 1, using the ultrapulse mode, you do a pinpoint irradiation, like how you do it for the ice pick scars. Step 2 is in the superpulse mode. You shoulder all the edges of the individual scars. In step 3, do fractional laser of the individual scars, and step 4 is fractional laser of the here. Here you reduce the beam because otherwise you can't see the scar. It's very important to reduce the beam. First, in the ultra pulse mode, you just go over individual scars. In the second, you just shoulder the sharp edges. See, I'm just going round to you do the entire area. This is the biofiller or the plasma gel. It does not last for a very long time. Maximum it lasts is for 2-3 months. But but it's a very good technique for resource poor patients who cannot afford anything, and if you don't know how to do a fat transfer. So what you do is just like doing the PRP, then you take the PRP and the PPP and you put it in a water bath for 1 minute, and you get the gel and you inject the gel. How many of you are doing biofiller? Everybody doing? So this is a very easy thing which
Very
you can
good
do.
thing. Short term.
Just how you make the PRP. Take both the PRP and the PPP. If you don't have water bath, you can just put it in boiling water also. Then you withdraw it and then you inject it. Then this is fat transfer grafted. This is your equipment, what you need. These are the donor sites. My go-to donor site is the posterior thigh. This is what I prefer. This is the procedure. show you this is the combination of after giving tumescent anesthesia, you take a liver lock syringe. This is a (10 cc) syringe. You attach it to a cannula. I usually use 3 mm cannula. You make a small nick after giving local anesthesia and you withdraw the fat. It is very important to wait for at least 20 to 30 minutes. Only then you will get this bloodless fat. And after you get the fat out, there are 2 ways by which you can process. Either you can centrifuge it, but I just prefer the decantation method. That separates out like that. So you just remove this fluid because it contains a lot of other tumescent anesthesia. Of course, it does contain little stem cells, but it's okay. We just want to inject the fat. And for the microfat, you inject it as it is, and this is how you prepare the nanofat. You need a connector. You have two sizes, 1.4 mm and 1.2 mm. And, you get a little yellowish tinge initially, you know you're in the right plane. These are some of the patients treated with fat transfer. This is just the nano fat and the micro fat. You can see the improvement in texture. This I have done under, you can do it under local anesthesia, but only thing, it's better to give a field block because sometimes when you inject the local anesthesia, the scars will get effaced. So very quick, a patient can tolerate just with the topical anesthesia, and you may require just do a fanning movement till you get a very free movement, and there is a little in the surface, you know, you get this sort of opening, but it usually quickly heals out. The other technique is with the Elman I give about 3 or 4.
3 or 4.
Yeah.
That's quite high, isn't it?
Pardon? Yeah, it's quite high. No, because if it is not high, it will not move very easily.
Okay.
Yeah, you here basically you're destroying the thick fibrous tissue. Different equipment can have different energies. How you find out if you are in the right energy? If the tissue is sticking and not moving, that means your energy is low. And if you are getting too much of charring, or if you are getting a lot of plumes, that means your energy is too high. So you have to balance it. So these are the complications you must remember. Getting too much of charring, or if you are getting a lot of plumes, that means your energy is too high. So you have to balance it. So these are the complications you must remember. You can get complications. For example, is this patient initially had a lot of cobblestoning. The chances are much less with the fat transmission, with the dermal grafting. This is with the fat transfer. What we say is put small pearls at different intervals. Summary of all the difficult acne scars which we face and how you can combine all these techniques. In conclusion, acne scars are common and challenging to treat. A systematic approach is ideal. Counseling is very important. The fast technique improve ice pick scars, and fat grafting is a useful procedure for volume loss and texture enhancement. We always learn from each other. This is my book where I have given step-by-step treatment. If you have some newer techniques, you are most welcome to tell about your newer techniques. Thank you so much.
Because there is a flare up after comedone extraction. There are not one case but many cases. To do steaming is the comedone extractor. Dry face is
come on the dash. I'll request our previous speakers, Dr. Munish Pal and Professor Dilip, to come up on the stage, please. After the presentation of Vimalti, we'll have a photograph. I request Professor S.K. Singh to give the patta.
Side se.
शुभम
I request our scientific chairman, Dr. Sirka, to present the memento and certificate to Bill. Kachwa, the first speaker. Please stand. I request Professor S.K. Singh to present a memento and certificate to Dr. Munish Paul. And we'll have a photograph together.
दीपक साहब सुनो ना, हम लोगों का तो इससे प्रोग्राम स्टार्ट है, तो सारा मामला तो लेके नहीं जी सकते, लेकिन घुसा देगा दोनों साइड से ताला मार दो, ठीक है? नहीं, उन लोगों को कुछ माल घुसाएगा, घुसाने का कंपनी का, ठीक है? हाँ, इसमें फिर सुबह निकल देगा, आपको फिर कल सुबह 8 बजे से जल्दी है आपको फिर आज की छुट्टी यहाँ पे।
So we close this session for the day, and I request you all, those who are interested, to go to the MSN or reception. Adjourn this for the day. Come around 10 o'clock. We start. Sorry, quarter to 10. You come by 9:30, and quarter to 10 we have a good session which you like. Thank you very much.